Discuss clinical cases, and we'll start with a clinical case by Dr. Zabarovsky. He'll present two clinical cases.
Thank you for the chance to address you here at this conference. I'm going to present two cases from Redden Institution, St. Petersburg. This clinical case is a woman, 56 years of age, that had an acute pain syndrome in lumbar area. She has undergone MRI, and we saw a fracture, a pathologic fracture. Doctors consider it to be because of bone loss, and took the patient for a vertebroplasty. 1.5 years after, this patient came to our hospital again with deformity of the spine, progressing deformity of the spine, also with mild paresis and intensive pain in lumbar area. We tried to restore the spinal axis, did decompression. Then we took the material for histology and saw multiple myeloma there. In post-op, we conducted chemotherapy to the patient. Then she was dismissed, and several years after, she came to the clinic once again with instability. These images are not ours, actually. Here, encircled with a red line, you can see an unstable screws. Also, she complained on pain in lumbar area, and we decided to extend instrumentation to TH1 and to sacrum on the other end. Here is how the thoracolumbar area looks like. It's quite okay. The axis is intact. There's no significant deformity there. But once again, in a year, this patient came back with a fracture proximal to the instrumentation level, with proximal kyphosis. However, without any impairment of the balance. The lordosis is adequate, rather adequate. And we took this patient for fixation up to TH4. We corrected the deformity with osteotomy, and a good clinical result was achieved here. Do you have questions, by the way, on the first clinical case? Maybe we discuss it. Do the audience have any questions? Why, upon the first admission, you didn't make biopsy to the patient? I cannot answer because she was admitted for the primary surgery to a different clinic. Yes, if we got the biopsy right away, if they got the biopsy right away, it would change the tactic. The surgeries here were multiple, and the duration is very high. Perhaps you were right in tactics, but somehow, if you receive the patient, why did you determine all the parameters of the spine upon admission? Why did you limit just by X-rays? we did a stabilizing surgery right away to remove the pain syndrome and to stabilize the spine. These kind of patients are not straightforward. It's not clear in many cases how to stabilize the spine because it's a tumor and therefore the prognosis, the life expectancy is unclear. And therefore we were not clear enough what to start with, what diagnostic tests we had to perform. We need to do everything possible to stabilize these oncologic patients, but uh, it was a very nice, a very interesting question. We are discussing post-tumor deformities now. These patients are a special group of patients. We are developing this problem now. If they have tumor in patient history and the stabilization in history for 3 years, and the quality of life suffers only because of deformity, then we stabilize this patient as for as long area as possible. But we keep in mind that it can lead to unexpected consequences as to the quality of life. But we try to reach long stabilization.
But when we cannot forecast the survival of this patient, of course, it's very difficult to choose the procedure. But we get these patients more and more often, and you get these patients now. So it's a real problem what we can do with these patients. My point of view is simple. When we have pain syndrome, when we have an emergency with compression which is worsening, it is clear. But when patients are admitted to the clinic, they are tested in many ways. And then when we check the tumor spread, we can see the situation. So we have to test fully, and we also have to test fully for sagittal balance. And then we can forecast their survival for as 2 years, 3, 5 years, 7 years. And then we say that the quality of life should not suffer, not just the tumor, but also imbalance. Please pay attention to this X-ray. There was breakage. Unfortunately, we didn't have X-rays immediately post-op, but they're not much different. And balance is actually okay. Balance is quite restored. We have lumbar lordosis, and the spine was quite balanced after the operation. So this is actually quite discussable. Позвольте.
I think it's not true. The C7 line is going down to the sacrum. This is not balance. This is just a position of C7 over sacrum. But if you check here, she has a disharmony of correction. She has a low pelvic incidence, 45, and there is a high amount of lordosis inside the instrumentation in the lower part. So this is the beginning for overstress at the junction between the upper part of the instrumentation of the spine above. And the patient has no other options than to develop a kyphosis at the junction.
Yeah, I agree with you, but I mentioned before that this region, thoracolumbar region, was strange. I mean,
Yeah, I understand. But what I mean is that there is a great amount of lordosis between L4 and S1. And so the upper part of the lumbar spine is pushed forward. And so the patient who puts the head over the pelvis has to develop a kyphosis at junction. There's a lot of pain in that, and particularly when the correction is done at the upper part. But here you have to adapt the amount of lordosis to the pelvic incidence. There is not one ideal lordosis. There is a certain amount of lordosis according to the pelvic incidence to make a patient well balanced to avoid overstress at the junctions.
Thank you for valuable comment. Второй случай. Пациентка, которая неплохо бы проиллюстрировала вчерашнюю дискуссию.
The second case is actually an illustration to the yesterday's discussion of osteoporosis. Unfortunately, I don't have imaging from 2005 or older images. In 2005, she had pathological fractures of the lumbar spine with neurologic deficit and pain in the back, and she was stabilized in the lumbar area with augmentation of the end instrumented vertebra and vertebra above instrumentation. And when this cement was introduced, there was anaphylactic shock, I think, in the patient. Patient got anaphylactic shock, which is actually very important because it relates to our chosen tactic. And though the upper instrumented vertebra and vertebra above instrumentation were strengthened with vertebroplasty, she still had proximal fracture. So what we can see here is the instrumented vertebra broke, had fracture. So we decided to prolong the fixation to go upward, and we decided to avoid transpedicular screws in thoracic region, so we choose hooks. We chose hooks for this. But we see that lordosis is not corrected. She has a flat back, so fixation loosened. And of course it was an error in biomechanics, because hooks were inserted almost at the apex of kyphosis. Then we did this fusion. We went even more upward, again with hooks, because she was osteoporotic and we thought that screws would be unstable, especially when the spine is imbalanced. But sometime later, the patient had a fracture near hooks. Sorry, the posterior support broke and hooks went out, and we needed to do a decompression, and we removed implants, which we didn't really want to do, but we had to, and we hoped for fusion, for spinal fusion, for osseous block. We couldn't fix anything in the thoracic area because she was so osteoporotic. Though she was on medication, she still had very low bone density. Sometime later, her deformity increased in thoracic region, and she was admitted in this state. My question to the audience is, what would you suggest for this case? If we maybe PCO at lumbar region? Okay, no votes for PCO at lumbar region. we decided to do PCO at the third vertebra, and we restored some balance. Not ideal balance, but some balance. And we got kyphosis in the thoracic area. But she later developed kyphotic deformation, so we had to do a revision surgery, and we implanted some cement, because when we saw that she cannot be fixated just in the lumbar area, we did all the allergy tests possible, and we saw that she's not allergic to bone cement. Maybe the previous cement was with a special formula or something. So we managed to stabilize the thoracic area and achieved quite a good balance. And we didn't fix to pelvic because L5S1 was in good condition. So we achieved good clinical result. Any questions?
I mentioned this in my lecture yesterday, where you have previously instrumented and you're going above or below, you should keep the instrumentation for the whole thing. Because when you remove the instrumentation, a lot of times the deformity will recur. Because two reasons. One, the segmental instrumentation is so strong that our fusions are not as robust as they used to be in the past. And the other thing is that when the instrumentation or there's some fusion, the whole spine is stress shielded, so it's weak. So you can either get fractures through there or the deformity will recur. So you should try to keep the instrumentation there instead of taking it all out. I'm sure you tried and you couldn't.
Yeah, thank you.
Ну, здесь маленький комментарий, если можно.
Small comment here. This patient is a kind of desperation at every stage. We had to remove instrumentation because she had fracture and she had pain syndrome above instrumentation. And as she did not react to bone cement, as you could not fix with hooks, because hooks went out, so that's why in desperation you decided, okay, let's take everything out, maybe she will live like that. They were in despair. But when she came back with pain syndrome and reduced quality of life, we thought maybe there is some problem. So we sent her to allergologist, and they did allergy tests to blood cement. And we had to risk her health once again and try to fix it once again, but luckily we managed to do it.
Interesting case. 2 points. I fully agree that in this kind of patient, osteoporotic, you remove the implant, you have 100% risk of progression of the deformity. See, even if it looks a continuous fusion, it's not a side fusion, it's a deform fusion area. The next point is, personally, I never use Siemens, or hide Siemens, because I think that when it moves, you have much greater risk and a big hole in place of the cement place. So I think the important thing is to share the fixation at multi-level and not to work each level, but to work in a segment, long segment, when you correct using the domino connectors as a junction when you do the correction with the osteotomy, with the 3-column osteotomy, but work on the whole area, not one level by one level, because it's overstressed at this level. And in fact, even in an osteoporotic patient, I never use any cement.
Thank you.